Over to the next session. Poisoning is a serious worldwide public health problem. Number of patients presenting to the emergency department with overdose, both intentionally and accidentally, has been increased in the current days. So the next topic for today is about toxicology.
Chairperson for this session are Dr. Lizy, Vincent and Dr. Vijila. She is a family physician trained in Otanjatram. She, along with her husband, pioneered primary healthcare for the Malto tribal people in Jharkhand. Has set up 30-bedded hospital named Prem Jyoti. Currently, she is practicing in Kodaikanal.
The speaker for this session is Dr. Narendranath Jhana. He is the Director and Clinical Head of Institute of Emergency Medicine, Senior Consultant and Head of the Department of Accident and Emergency Medicine, Meenakshi Mission Hospital and Research Center, Madurai. He is the President of Indian Society of Toxicology, Founder President of the Indian College of Emergency Medicine. He has received the Academic Entrepreneurship Excellency Award for contributing wellness and growth of academic atmosphere in India. He is the recipient of Global Leadership Scholarship Award from the American College of Emergency Physicians USA 2018 and the editor of Clinical Toxicology, a case-based approach, published in 2021. He had published more than 170 articles in national and international medical journals. Over to the chairperson.
It's my real pleasure to invite Jhana sir. Jhana sir, I know in 2011 MCon. Basically, I presented a paper there, and that's where I came in contact with him. And still now, we are great friends and colleagues. And he's one of the best speakers in toxicology you can get on stage. Thank you. I welcome Jhana sir and hand over to you.
Good afternoon. Good afternoon. You are not hungry? I don't know, most of the time the organizing people, they keep my lecture either pre-lunch or just post-lunch. I don't know what is the mechanism on that. First of all, okay. So first of all, I would like to thank the organizing committee, particularly Dr. Pranita Madam, for inviting me for this talk. And our mentor, Dr. P.K.M. sir, is here. The previous talk was fantastic. Dr. Raman probably here. He is supposed to leave. But it's a really fantastic talk. I don't know how much I intend to family medicine. Probably most of the people, they don't know that when I studied in CMC Vellore, I also did my family medicine under Dr. Jason here, probably. Dr. Jason? Dr. Jason, ma'am, probably here? Jason, yeah, sorry. Dr. Jason. So, Dr. Raman was talking about so many things regarding the family medicine. But my observation is one thing, I didn't find any family medicine whom I seen last 15 years back, they have changed. They are same like we people are become old, but the family medicine people become same sweet people. Even Dr. Raman, Dr. Lancy, Dr. Lizy, I have seen them 15 years back, but they are exactly same. But I become old. I don't know what is that is the beauty of probably family medicine. And yesterday, though, I wanted to be here, but I could not stay here because probably this conference is very lucky to me and our institution. And we received the best emergency and trauma care award by the CIA Tamil Nadu Enclave from the Honorable Health Minister yesterday, this time. So I was receiving, so I could not attend. So I think your conference is lucky for us as well. So Dr. Raman was talking about a few things. I have observed Dr. Raman, how he has done hard work to develop this specialty. This specialty was not there, 15, 20 years back. When I did also like my family medicine in CMC, that time very few people. But you look today, I was told that close to 300 people registered for this conference. I never seen recent past that so many people have registered for any conference in this hall. So please give a big hand for you people. I am really blessed that for the state conference, even from Bhubaneswar, some doctors has come here. So this shows the leadership of the leaders in family medicine. Who said family medicine is not a super specialty? I am not agree with Dr. Raman that family medicine is not a super specialty. You are the superhero, like emergency medicine. There's people, they say, if the emergency medicine, EP, and emergency medicine and family medicine is the two pillars of the healthcare system. You see NHS, National Health System in UK. The family medicine people are the most, probably highest paid, even same like neurosurgeons. And getting a family physician is very difficult. I have few friends, those who are most popular in UK, and getting appointment, and they have very good relationship, also most of the trust hospitals. So they are very, very popular, these family physicians. So please don't feel that we are some less than any super specialty or any specialty. You are the hero because you are diagnosing most important thing, and the relation between the patient and the healthcare system, you are the bridge. So please always think that we are the best. So 3 P's, again I have seen the leaders from these specialties. They have passion to grow, they have persistence, and they have passions. So with these 3 P's, now you can see close to 300 people registered here. So definitely there is a wonderful growth in this specialty. So if I talk about poisoning, I was given a talk about poisoning care and why it is important. If you see, according to the WHO data, close to 0.3 millions of people, they die because of poisoning in the world. And if you see Indian statistics, according more than 1,050 patients, those who take poisoning, close to 50 patients, they die. So it is a huge problem. It is a public health concern. It's a public health problem in India. But these patients, when a patient consume poisoning, where they goes? They goes to the family physician first. They goes to the GPs. And if you treat systematic approach, if you know some antidotes, if you know the signs and symptoms of few poisonings, probably we can reduce the mortality and morbidity. And the most important, we see in the emergency department, they comes to the emergency department after 6, 7, or after 1 day as well. So the first person who treat poisoning, most of the time, it is the GP, general physicians, and the family physicians. So you have a wonderful role in managing poisoning. I'll just go the systematic approach, what we can do or how to diagnose the poisoning patient so that we can save many more lives. So the objectives is very simple. The objectives are, we have to familiar with the sign and symptoms of the poisoning victims and how to treat. If it is a patient is having an emergency, then of course, if you don't have that accessibility or needed instruments or training, definitely we have to send to the emergency department. So of course, this is the lunch time, but I have a gift for you. The people will give answer. I will give a gift. The first question is, indication for intubation in poisoned patients except obstructive airway, laryngeal edema, bronchoria, GCS more than 9, or depressed sensorium. Please pick your hand. The Cadbury chocolate is ready. Oh, fantastic. I have tie. But first person is that side. GCS more than. Please give a big hand. Please give a Cadbury chocolate for him. What's your name, sir? What is your name, doctor? Oh, Kingsley. Second question. There is so many chocolates are there. Second, don't think only one chocolate. The drug which doesn't cause bradycardia. I think most of the people you know. Clonidine, ethanol, digoxin, beta agonist. No, I will not give like that. You have to pick your. Somebody said alcohol here. Anyone? Somebody pick the. Yeah. Please see. Let's see. The answer is beta agonist. Chocolates is next. Roll over. Which is not a coma cocktail. Quick. Dextrose, thiamine, insulin, naloxone. Who said here? Insulin, this side. Okay, please give a chocolate to her. Prabhu, chocolate to her. Next question. Contraindication for gastric lavage. Everybody should know. Contraindication for gastric lavage. Conscious patient, within 4 hours of presentation, unconscious patient, none of this. Contraindication for gastric lavage. I said you have to pick your hand. Chocolates is there. I can see there. Conscious patient, the answer is unconscious patients. Next question 5. Activated charcoal doesn't absorb everything except corrosive, heavy metals, alcohol, cyanides, OPS poisoning. OPC, corrosive. OPC or corrosive? OPC, please give chocolate. Adverse effect of activated charcoal include all except constipation, intestinal impaction, charcoal, diarrhea. The ties, give to that gentleman, yes. Diarrhea, yes. Dose of insulin, infusion in calcium channel blockers, overdose. I will give 2 chocolates to the right answer. No? No one? Okay. So the 2 chocolates will roll over to next question. 0.5 to 1 unit per kg per hour. Endpoint, sign of atropinization. Everybody knows. Good. So this side, the person who is recording. So the last question is, when is calcium gluconate is contraindicated? 3 chocolates. Whatever the left chocolates. Whatever the left chocolates you will get, maybe 5. Lottery. So nobody picked the 4 hens. They said, but nobody picked the hen. Okay, fantastic. Oh, now after the answer, good. So, over. Chocolates we can get. Chocolates will be given to the chairpersons. So, what is the poison actually, basically? Basically, this is the textbook definition of poisoning. You see, the poison is a not new thing. It is since 1453. The father of toxicology is Pasteur. What he says, all things are poison, and nothing is without a poison. It's a dose that matters. Even the paracetamol, even the glopulate, whatever we take for the emergency, if you take more than what is the desired dose, that becomes the overdose, and that makes sense. So, the fundamental, when we are talking about poisoning management, we should know these 5 important things. 5 important things, nothing else. So, if we know these 5 important things, then probably we can help to reduce the mortality and morbidity. What are these 5 things? The first important thing, when a patient having poison, we know the vital organs depends the vital signs. So we have to support the vital signs like heart rate, blood pressure, respiratory rate, temperatures, okay, even blood sugar. This is very important. The second most important thing, the prevention of further poison reabsorption. That is also important. The third, enhancement of poisoning elimination. We have to try the as early as possible that poison should go away, removed from the body. Fourth is, of course, antidotes. And fifth, prevention of re-exposure. We don't give more importance to re-exposure. So these are the emergency management. What we all should know, probably all doctors we should know, irrespective of any specialty. Because this poisoning, out of 10 doctors, anybody, I think we will have in your life either ourselves or our family members or our near and dears. This is not a new thing. Either poisoning, either overdose, or either any forms. We encounter this type of problems. So what is the important, when it's a doctor, what we supposed to do when a patient having poison? Of course, first is very important ABC of the resuscitation. We should know what we supposed to, something we should do that patient should not die. That is most important. Second important, the decontamination. Third, gather information. These are 10 points. Out of that, fourth, prevention of re-exposure, treat associated conditions and injuries, enhanced elimination support, antidotes, lab investigation, disposition of the patient, and medical legal documentation. So as a family physician, we should, to be a good physician, Dr. Raman was talking my slides, but my views, remember 5T. First important thing, as a family physician, first important thing, talk to the patients. Dr. PKM sir was talking about communication skill. We people should be a master in communications. So first T, talk to the patients. If patient is conscious, if patient is unconscious, definitely talk to the relatives or the patient who brought to you. The second T is touch the patient. That means clinical examination. The clinical examination is the key most of the time in poisoning patients. And third, of course, test the patient, the very specific test that we should do. Fourth T is treat the patient. And fifth T, transfer the patient at the right hospital or right specialty, which is required that particular time. So ABC, airway, breathing, circulation, I think all physicians, irrespective of family physicians, we should know. And if you having also a clinic, you should have a basic instrument to, to make the patient alive. A patient having sudden cardiac arrest in your clinic, what you will do? You should know how to do CAB, compression airway breathing. So emergency medicine and family medicine, it's a twin tower. It's the two sides of a coin. And you see, basic emergency medicine, if you learn, I think everybody learn. Basic emergency medicine, if you learn, your clinical practice will grow. And I have the same thing I have found in myself. I learned family medicine, critical care, emergency medicine, and I found that we can save many, many more lives. So what airway? I'll just give a basic idea what we're supposed to do. Airway, what I'm talking about airway. Basic. We don't have to go so many things, basic airway, advanced airway. So basic understanding if airway is compromised. That means if airway means patient is not able to breathe or patient is gasping. So that means the airway is compromised. So we have to think about definite airway. If airway is patent, if patient is talking to you, patient airway is fine, then definitely we should think about what's the sensorium. If sensorium is compromised, then definitely we have to think about definite airway. Otherwise, if after intubation or after definite airway, we can proceed for the resuscitation. If the airway is patent, sensorium is patent, then definitely we can go for resuscitation. Very simple. I will make you very simple. So what is airway? Airway, as I said, ensure that patient is talking to you. And second, if patient is having, there are many patients after poisoning, there will be lot of secretions from the oral cavity. Then we have to do suction. So suction out the secretions, and we have to think whether the patient is having ability to protect the airway. The tongue should not fall. If it is there, just push a oropharyngeal airway. You save the life. Not necessary that everybody should learn how to do intubation. But if you put the oropharyngeal airway and just give ambu, you save the life. Very basic. But for every family physician, I think I have seen many family physicians, they just put the airway, oropharyngeal airway, and put the ambu, and they brought to the emergency, and they saved the life. And I have given the credit to them. Fantastic work they have done. Indication for intubation in poisoning, either for the airway protection or for the mechanical ventilation. These are the either airway protection, certain poisoning, air dye poisoning, many poisoning, we have to protect quickly airway protection and for ventilation, OPC poisoning, etc., etc. And after airway, breathing, how will check breathing? Simple. Saturation, probe, and you can SpO2 check whether the saturation is maintaining more than 90% or not. If not 90%, less than 90%, definitely there is a red signal. So always oxygen by non-rebreathing mask, or if you have an ambu, you can do it yourself, not a problem. Observe the breathing pattern of the patient, how he is breathing. And of course, you can ventilate through the ambu bag, even from your clinic, not a problem. So breathing, either ventilation failure due to these types of problem, or disruption of oxygen absorption due to pneumonia, pulmonary edema, or cellular hypoxia, even cyanide, hydrogen sulfide, or carbon dioxide poisoning. So patient can have a bronchospasm after some type of poisoning due to direct irritant or pharmacological effect or hypersensitivity, so that we can ventilate as early as possible these patients. After airway, breathing, now circulation. If you are well, to put a cannula, start a drip, then definitely you can give some fluid. There is no harm. If patient is suddenly hypotension, patient is, blood pressure is low, you can give some fluid. So monitor the heart rate, rhythm, and regularity. Monitor the blood pressure. If patient is hypotension, of course, very simple, in the primary care level, we can start 2 large bore cannula and start fluid as early as possible. These are the synonym. If you are sitting in a clinic, patient had some poisoning, and you have checked the blood pressure, the patient is having a hypotension. Then this is crash. Then you can find, patient can have probably taken some cancer-channel blockers or prizorpine, antidepressant, or sedative, or some type of, opiates. So crash, you can remember crash. If patient having hypotension and some type of overdose. If patient is having bradycardia, then the synonym is paste. Beta blockers, particularly propranolol, anticholinergic drugs, or clonidine, ethanol, or digoxin overdose probably. If the patient has taken this type of drugs, then patient can have even heart rate 40, 50, bradycardia. Patient can have a tachycardia. These are the drugs can cause tachycardia to the patients. And simultaneously, patient, this is very important when you are sitting in your clinic, the history of the patient. That's why second T comes to the picture. Either talk to the patient, first T, talk to the patient, or patient is unconscious, then definitely talk to the relatives and take as early as possible, as much as possible, the history is most important. The risk assessment, how we will choose the risk assessment of poisoning patients. Then here we should know about 5W, who, what, when, where, and why. This 5W can make sense to know what type of patient poison has taken, what when, and all this data, so that you can refer the patient at the right hospital at the right time. And most of the time in poisoning victims, the history is not true. There are many papers has been published where they found only 30% patients, they tell the truth of poisoning, what type of poisoning, how many drugs they have taken, what type of medicine they have taken. And when I was doing my residence in CMC, I did a study, my thesis was on poisoning. And I found more than 546 patients, they took poisoning. And majority of, very interesting, a majority of poison taken by females. But majority death happened by male. This is the, and when the females, they take poisoning, for why. Even sometimes they just, they just want to, for angry, or sometimes, but when male takes poison, they takes with alcohol and multiple drugs, even OPC and different types, and sometimes it's a problem. The mortality is high in poisoning, or the majority times are male. Physical examination is most important. This is second T, the clinical examination. Access the GCS, skin. We can find, you can see, if you examine properly, we can find what type of poisoning they might have taken. Even sometimes they may not tell the truth. But if you will do the clinical examination, the colors, the different looks, cyanosis, and most of the time we can predict, yes, this type of poisoning might have he has taken. And simultaneously, if you do the clinical examination, head to toe examination, we will find the diagnosis. So what are the cause of altered mental status? So these are the basic AEIO tips. If you see, majority of diagnosis comes when a patient comes with altered mental status, and most of the one is poisoning. And of course, many causes, many differential diagnoses are there, but one is poison, one is overdose that patient may have, this cause of altered mental status. So these are the very important that we should have the clinical examination so that we can diagnose as early as possible. So this is very important. So when you are in doubt, now you can see in this picture that you will not appreciate anything. You don't know what is this, but if you very closely, if you will see, now you can see this is here, it's a snake. This is a snake. So it is very important, particularly in poisoning, that we have to go deep, very deep into the history and find as early as possible that what type of poisoning that he or she may have taken. So when you should suspect whether the patient is having poison. So this is two important things. Either a patient is having altered level of consciousness or unexplained sign and symptoms. When patient, you don't understand, something is wrong with these patients. I have checked the blood sugar, I have checked the BP, heart rate, everything looks, something is abnormal. Oh, that means this patient might have taken something. So think about that patient might have taken some poisoning or overdose. If you think, then your assessment plays a big role here. Please assess the patient very quickly assess. If you assess properly, particularly if you see the vital sign, physical examination, neurological, skin, all these orders, you will find yes, there may be something patient might have taken some poisoning. Coma cocktail, we had a question on coma cocktail. Earlier, when there is a bedside diagnostic was not available, particularly blood sugar, those days when we do use coma cocktail when a patient is unconscious or altered mental status, but now we don't use this coma cocktail because the bedside tests are available now everywhere. So we can know if hypoglycemia, we can give the dextrose. If patient is alcoholic, we can give thiamine. If patient is some overdose, we can give naloxone. Naloxone we can give. So we don't require to use now coma cocktail like earlier, 15 years back. So that is how naloxone is so important, that American Heart Association in 2021 guidelines has been changed, and they put naloxone as a primary drugs to be treated. This is antidote for opiates overdose. If patient is suddenly unconscious and they found patient may have taken opiates, even the pre-hospital care, even paramedics can use the naloxone. That is how the American Heart Association has improved the pre-hospital care in the recent guidelines. So after airway, breathing and circulation, now comes decontamination. As a doctor, as a clinician, what's your role for the decontamination? The decontamination means the skin decontamination, remove contaminated clothings, and always universal precautions is very important. It's not only the patient is having a problem, if you will not follow the universal precautions, you will have also problem. So that's how it is very important, and as per the medical legal issues, we have to keep all these patients' clothes and other things packed and separately. That is how it is very important. And decontamination not only just remove the clothes, we have to look after everything. Now you see all the parts. So that's why most of the medical colleges now, they have a decontamination room or negative pressure room close to very emergency department. That's why we should know that decontamination is very important to play a role in treatment. That is very important. So GI decontamination, that is not only the gastric lavage. So gastric lavage is very important when supposed to required, and we should know which patient we should give gastric lavage or which patient we should not give. So gastric lavage, the decontamination, the gastric lavage we should give, the exposure is expected to cause a significant toxicity. Very important. In Europe, Australia or in UK, they don't give much importance to the gastric lavage, but we give gastric lavage. Why we should give? Because we take multiple drugs, multiple alcohol, biryani, many things, OPs, organophosphate. So we take different types of, so if patient comes within 4 hours, so it's better to do that, gastric decontamination. So gastric decontamination can be divided into induced emesis, gastric lavage, activated charcoal, catheterics, whole bowel irrigation, endoscopic removal. So I will say you, induced emesis. Earlier, when we used to say somebody has taken something, we induced emesis, vomiting. But now it's not recommended. It's not needed, absolutely not needed. We should know. But gastric lavage, yes. What is the indication of gastric lavage? It's very simple. When the patient is taken life-threatening poisoning and unconscious presentation within 1 hour. And definitely unconscious means presentation means there is something very high dose. And we have to gastric lavage, we should do after the securing of the airway, that I will tell you, or something tablet poisoning with anticholinergic effects presentation within 4 hours. Same thing, sustained release preparation, particularly certain medicine of OHA, diabetic medication, sometimes antihypertensive medicine, sustained release, OD dose when we give. Then if patient is taken more tablets, there is a role of gastric lavage, and of course iron and lithium poisoning. When contraindication, when we should not do gastric lavage, and of course when there is a corrosive poisoning and comatose patient, secured airway first, then do the gastric lavage. Why children they die more in poisoning or overdose? They don't die because of poisoning. They do because of pneumonia in ICUs, because wrongly we do gastric lavage. Now we should know how to do gastric lavage. This is a very important, most of the textbook not written how to give gastric lavage properly, accurately. We have to do left lateral position and not use rice tube. First aspirate the stomach content. What we do in the gastric lavage, if you will tell your nurses or junior doctors, they will put the rice tube and start the saline bottle. We are not supposed to do that. First put the saline, put the rice tube, then take out the content from the stomach, what patient already have. Then do the use normal saline or clean tap water. In CMC we use to clean tap water. Infuse 200 nod. Be there when you are doing gastric lavage. Don't depend on nurses or junior people. Teach them gastric lavage. Gastric lavage is a part of treatment. If you don't do, saline bottle is going on and patient can have aspirate pneumonia. Very simple. Okay, patient complication, aspiration and trauma, and sometimes patient have a bradycardia and death, sudden cardiac arrest. This is how we used to do when I studied in CMC Vellore 16 years back, 17, 18 years back. We used to do gastric lavage. This is my, I used to do there, my nurses and my paramedics in CMC Vellore. Now we don't have to use that tube, we can use gastric lavage in rice tube. And the procedure of gastric lavage very simple and very paramount. About 200 to 250 ml of water to be used each lavage, not more than that. But pediatrics, the dose is 10 to 15 ml per kg body weight. Lavage to be done until clear fluid is seen. Very simple. Contraindication, of course, the corrosive poisoning, hydrocarbon poisoning, and unprotected airway. A patient is GCS is low, patient is unconscious. Again, I am telling same thing. Until unless the airway is protected, please don't do the gastric lavage. Complications can cause. Majority of pediatrics age group goes the first aspiration pneumonia, laryngospasm, mechanical injuries, fluid and electrolytes imbalance, hypoxia, even death. Activated charcoal, it is called universal protection, antidote, universal antidote. I think everybody should have if you are practicing. So, it's a carbon superheated in absence of oxygen. What is called? Charcoal, activated charcoal. Small holes 100 to 800 angstrom, surface area 1 gram to 1000, highly absorbent. And that's why it is called universal antidote. So, for children we use biscuits, chocolate charcoals. And the study says multiple doses of activated charcoal is very useful, particularly in primary setup, primary care. And first dose is 1 gram per kg body weight, subsequent next dose is 0.5 gram per kg body weight, and useful for primary health care service. That is how to give the gastric lavage, and suddenly. Can you, hello? Can you, please? Start from there where I finished. Yeah, start there from where I finished. Just put, go. Recap all the presentations. Yeah, stop. Yeah. What is the adverse effect of charcoal? Of course, patient can have a constipation, patient can have gastric distension or vomiting, patient can have. So, next is catharates. Catharates is nothing but it's a magnesium sulfate or it's a sorbitol, and we can utilize as especially as a laxative. And earlier probably we have, but there is just some contraindication, particularly in corrosive, severe diarrhea, abdominal trauma, and renal failure patients. Whole bowel irrigations, so particularly these patients when the patient has taken heavy metals or sustained release medicine, PEGLEC, the dosage is 500 to 2000 ml per hour we can use. Enhanced elimination, that is urinary alkalinizations, particularly in salicylative poisoning, overdose. Extracorporeal removal, you should know for the sake of when you are referring a patient. Very recently, one patient we admitted, the father of an IS officer here, very close districts, and he had a snake bite. And first, the PT-INR was normal, first set in the respective their hospital, but when the renal output was, urine output was not there, then they refer to us. And we know the certain group of poisoning, snake bite, that patient will have a renal failure. Renal failure. Then when patient came here, patient had absolutely no output. So we started plasmapheresis, dialysis. Then patient, after 3-4 days, patient went well, patient become well, started urine, and patient went back. So we should know that there is a role of plasmapheresis is huge and very important, particularly when there is a renal shutdown and due to snake bite or poisoning. So hemodialysis mostly used for the lithium, metformin or lactic acidosis, phenobarbital salicylate overdose. Hemoperfusion use thiopilin and paracute poisoning. Most of the patient hemoperfusion we do, charcoal hemoperfusion we do mostly for paracute poisoning. And CRT, continuous renal replacement therapy, particularly in snake bite or some certain of poisoning, it is helpful. As such as physicians, we should know about antidotes because that plays very important role to save lives. These are the basic antidote of the common poisoning, particularly acetaminophen means paracetamol overdose. We should use N-acetylcysteine, anticoagulant, vitamin K, benzodiazepam, flumazenil, beta blockers, glucagon, carbon monoxide, oxygen and hypercarbic oxygen cyanide, amyl nitrate. All these things, it is very important that we should have some basic when you are talking about poisoning, and it will helpful to save lives. Investigations in poisoning is very specific. We don't require here HbA1c or cholesterol or lipid profile or liver profile. We don't require. Very specific. Remember 5G. 5G is very important in very acute ill patients, in particular in poisoning. First G is ABG. Second G is beta HCG, particularly in female age group, females and reproductive age, CBG, ECG, USG. Other investigations, urine drug screening if it is available. Of course, chest X-ray plays very important role. CT, KUB and other investigation as per the needed that type patients. Radiographic examination, particularly when patient has taken something, we have doubtful that whether patient is having, it's a cardiogenic pulmonary cause or some type of poisoning, we can find. And most important thing, another for the body packers. Body packers means the drugs when the patient has taken and they are found in the airport, and these are we have found a couple of patients, and the airport officers, they brought to emergency, they suspected, we did X-ray, we found that patient had something inside. So X-ray plays very important role when you are talking about poisoning. When we are treating poisoning, not only we should only concentrate on poisoning, we have to treat associate conditions. Most of the patients, they may have diabetic, hypertension, ischemic heart disease, bronchial asthma, so and so. So we have to treat, and these patients also don't forget, if patient is unconscious, this patient may have a fall, sudden fall after taking some type of sedatives. And there may possibly patient is already taking anticoagulant or clopidogrel or aspirin. May patient after fall, maybe patient is having subarachnoid hemorrhage or SDH, EDH. So definitely there may be a trauma to the head or chest. So we have to see overview. Second, chronic illness, as I said, diabetic or hypertension, coronary artery disease, etc., environmental as well. So supportive treatment, apart from antidote, it is very important. What is supportive treatment? Ventilation if required, inotropes, correction of electrolytes imbalance, correction of acid-base imbalance, and correction of hyper and hyperthermia. It's very important. Where we should send these patients, of course, where the ICU beds is available or ICU facility is available, that is very important. And where we should admit, if ICU, when the patient is unstable or potential lethal overdose or cardiac toxic doses overdose. These are the criteria for ICU admission. Very important that when you talk to the referral doctor, we should know where this patient should be admitted. Very critical. So never discharge. If patient comes to you, to your clinic, oh sir, he has taken only 5 tablets of metformin, or he has taken only 5 tablets of Anxi tablet, 0.25. You don't know how many tablets he or she has taken. Don't believe. Only 30% patients they say truth. 70% patients or relatives, they will not tell the truth. So misdiagnosis. Again I am repeating, misdiagnosis is a potential medical legal pitfall. If we are not diagnosing properly, or we are not looking after properly, particularly in poisoning and overdose patients, then we are doing wrong things. It can be a possible. Yesterday I was attending with in Chennai with a legal consequence for doctors, and one is poisoning. So if we should not think you can over triage these patients. If we are not able to, we are not getting treatment, we can refer to the hospital nearby. You refer there and write. Documentation is very important, particularly in poisoning patients, because very important. So I will conclude that never withhold intubation, or if you are thinking a patient is sick and requires some type of ventilation, you should have a simple bag of emergency drugs and emergency kit. Every doctor should have, even your car. Keep a simple oropharyngeal airway and ambu bag. Save lives. If will not do, many patients they die. Even the doctors, one cardiothoracic surgeon brought his brother to emergency after having anaphylaxis. Here in near to Anna Nagar, one surgeon's wife, surgeon brought his wife after having some anaphylaxis. Okay, he has tried to give Avil injection but could not give adrenaline. So we received a broad dead. Many patients we have seen after anaphylaxis, patient die. So just a simple oropharyngeal airway and ambu bag can save lives. It's a documented, proved paper. Second, multiple doses of activated charcoal you can give in your clinic. That's a good thing. Okay, good thing you can give if until unless it is the requirement and indication for the activated charcoal. You can give. So it will, that toxin observation will be less. Third, supportive care is most important measures in poisoning patients. When in doubt, of course everything we don't know. When you are doubt, observe, send to the emergency department or some hospitals. When faced an unfamiliar or serious toxic, so many times we don't know. So never hesitate to consult a senior or toxicologist or having somebody. Nowadays Tamil Nadu government also having we are creating a poison information center in Chennai. Government is very proactively acting, and we have framed, including CMC Vellore, our medicine department, we have formed a team, and the very beautiful for the primary physician, for every physician, one book is coming up. So it will be very wonderful for all the physicians, and probably this will be the first very handy book for poisoning care for primary health. This is my book, and a privilege that last year we published. It's a clinical toxicology book we published, and I am very happy to share. Within 4 months, we sold out, the publisher sold out 1,760 copies. And a very beautiful book, and it's available in Amazon or every Amazon and Flipkart. And this is all the 51 cases we reported here, though patients came to our emergency here. And even a patient we could not save them, we noted there that we could not do it, or patient came late. So it is probably it came out very well, and we have started Indian College of Emergency Medicine. I am the founder president, and we have started a fellowship program for all the general physicians and family medicine people. We started a fellowship in clinical toxicology, 1-year course,
and 11 online program, and 1 class will be the contact program. So we have already started. In the first year, last year itself, we received 78 applicants, and we just taken only 15 people. So next year it will be there. So thank you so much for the invitation. I really, it's a privilege to have a photograph with my own profession when I started 18 years back as a family medicine and in CMC. Thank you so much for having me here. But I will tell you, I told you the first slide, that all my family physician colleagues whom I met after 15 years, they look same. They look same, though but I become old in emergency medicine because I'm thinking why I'm become an emergency medicine here now. I would have been family practice. But my slide is not over, my dear. My slide is not over. How come you say? This is my last slide. This is to you people. You know probably this gentleman. Very recently, unfortunately, we lost him. We lost him. You know him? Do you know him? Yes. What is his name? What is his name? Okay. You know how much money he kept in his bank for his family? You know? So it seems to be 60,000 crores. But what he said, you know, the first wealth is health. And I am sorry to say, I have 60,000 crores in my bank, but I am not able to enjoy. I am not able to walk. You might have seen his video, watched his video. I am not able to walk. I am not able to eat what I want to do. But in last video, he wanted to dance. So life is very precious, my dear friend. Money will come, money will go, but life will never come. I am seeing an emergency department for 3 to 4 minutes it matters. Many lives we say, okay, we failed to survive, have given them life. But many times we try our best to save their lives. We try. Most of the people, when they brought cardiac arrest, polytrauma, severe asthma, we try to best to save their life. Even doctor's life. Even many doctors had a cardiac arrest, they brought to emergency. We try our best. Why I'm telling, in Pune, IMA, they did a study. They found, you check in the Google, they found the doctor's lifespan is decreased by 6 to 7 years. So why we should reduce our lifespan for others? Because we are not looking after ourselves. Please don't run behind money. Money will come when your health is good. Thank you so much. So I don't say it is only money, wealth is, I say health is wealth. The two things, health and wealth we require, but health is wealth. Thank you so much. If any questions, I will give answer.
Thank you, sir, for that very informative and comprehensive session. I'm sure it has given a lot of tips for us. I think the first thing would be to get an ampu bag in every house. Doctor's house.
Certain drugs, 4 drugs, that is expert by you. It is aspirin, clopidogrel, atorvastatin, sorbitrate. You should have in your pocket. I have in my bag. And of course, you should have a ambu bag. Ambu bag, it is hardly 235 rupees, 400 rupees, the best ambu bag. And for oropharyngeal airway, that save 60 rupees. It save life.
Sir, if you cannot identify the poison, do you do a gastric lavage analysis for toxic substances, something like that?
Gastric lavage only to be given when there is you suspect there is, first of all, if our intent to do good things for the patient, and gastric lavage should not be done. First thing I said in my slide, if patient is unconscious, no need to be given unconscious. If patient is conscious, ask what he has taken. And there is no harm to do gastric lavage. In fact, if patient is not taken kerosene, hydrocarbon, kerosene, phenyl, all these things, gastric lavage is contraindicated there.
No, I'm just talking about the analysis of the gastric lavage.
Okay. Yes. There is certain centers are there. You can send that gastric lavage content. You can send, but you can send to Amrita. They have a center for analysis, but it will come after 48 hours.
So not necessary. Even the clothes, gastric lavage content, we keep in the box. This is a medical legal issue. We keep that police never takes. So it is a clinical, that's what I say, it's a clinical toxicology. As per the rule, as per the law, we should keep gastric lavage, the content and send for analysis, but never happens.
Thank you for the nice talk, sir. I am Dr. Loganathan from a rural place practicing at Ambasamudram. I've been treating poison cases since 30 years, saving a lot of lives. The most treated poison now, what I feel is that paracute. It involves a lot of systems, and all the systems, every system goes up. What to do on the initial stage, and how to follow it up.
That's a very difficult actually. Most of you might have seen in a practice that
Yes.
we lost many lives in paracute because of multiple organ failure. That's the problem with paracute. So early hemoperfusion, renal replacement therapy, that is the key to treat paracute poisoning. Otherwise, most of the patients, particularly aluminum phosphate paracute, we lost life.
I think we need to
So,
wind up. One
Another
last
question.
question.
Another questions, yeah.
Yeah.
May I? So thank you so much for this lovely, very, very informative talk. I'm so glad you highlighted the question of suicide. I think it's a very important aspect, and particularly as we all know that physician suicides are among the highest. And if I remember my statistics correctly, top is anesthesiologists and second is family physicians. And so we do all need to, as an impressionable group, keep in mind mental health as well. I'd like to comment on a reference you made that from your observations, although women take poison more frequently, the death among men is more. And I'd like to touch on a comment you made that we all know why women take poison. And so I take a little exception to that, because I don't feel that there is place for exhibiting gender bias in care towards patients nor towards colleagues.
That was my study in CMC 17 years back. So now time has been changed. Probably now male taking more poison seems. but it's...
Thank you, sir. So if anybody has more questions, you're welcome to send an email and we can forward it to him.
I'm available, you can ask me.
Yeah, I think we really need to wind up. And points to remember: our role as family physicians, be involved in preventive care, be quick in, be prepared to do what needs to be done in an emergency, and follow-up is very important. A patient who survived poisoning, intentional poisoning, follow-up, counseling, and if there is depression, treating that, all that is very important. Thank you very much.
I can appreciate, madam, that you said one word, mental health. I think the role of family physician regarding the mental health is enormous. I think the most of the physician, particularly family physician, they can do wonder, because you are direct linking with the patients, their relatives, and you are constant touching, constant having a conversation with them. So as a family physician role in mental health, it's very wonderful. I think we can play a wonderful role there, and to reduce the suicide, death or intention in patients in our country.
Thank you, sir. I request Dr. Isaac David to honor our speaker and chairperson.
So you all know, usually wife getting a award from a husband is difficult. So here is an occasion. Isaac's wife is Vijila ma'am, and sir is giving the prize to him.
Thank you, sir.